AstraZeneca, Gaurav Pratap, and I really welcome you all today on this weekend evening. And today we have the privilege of having Dr. Narendra Kumar. He's a young, but he has got various accomplishments and accolades to his name. And right now he's currently in UK, and really it would be our privilege today to listen to him. And just to say a few words about him, he is a European board certified cardiac electrophysiologist with his doctorate thesis in cardiology on atrial fibrillation ablation from Maastricht University Medical Center, Netherlands. And he is also a program chair for an international cardiology program. And his primary interest lies in the field of atrial fibrillation, arrhythmia management, heart failure, and cardiovascular economics. And he has more than 12 years of experience with him in cardiology, and he was also awarded NRI of the Year Award 2018 for academics by Times Group. And he is currently working at Manchester University Hospitals. And there are various other accomplishments. And with this, I would like to hand over the session to Dr. Narendra Kumar. And today he'll be giving a talk on the topic of Dapagliflozin, a new standard of care in the patients of heart failure with reduced ejection fraction. So, sir, it's really our privilege, and we really welcome you from India and would request you to kindly take us through the session, sir. Over to you, sir.
Thank you so much, Gaurav. It's really a pleasure for me to be able to associate with you, to be able to share this sheer amount of new knowledge which is coming out in front of us for the new molecule which is being appreciated, which we have been using for heart failure. And I must say, it's really an amazing pleasure for me and honor as well to be able to share some insights which we have been using this molecule for the management of not just in the diabetic patients, but we are aware the recent approval of this unique molecule for the heart failure patients as well is equally thrilling and amazing. So I welcome everyone as well for this unique CME platform, and we are thankful to our sponsors to be able to share the knowledge again. So let's try to go through what are we planning to go through throughout this, at least for the next coming hour. So what happens is we all are aware that the heart failure patients tend to form a good number, especially in our general day-to-day cardiology practice as well. And we do come across this problem, in fact, as well. So what happens is whenever we are trying to see in the general cardiology practice, heart failure patients are there. And in fact, it really feels sad, like even in 21st
Yes.
century, when countries like India are thinking to go to Mars or even distant planets, okay? But when we are thinking of a clinical entity like heart failure, still the morbidity and the mortality, in fact, is pretty high. So, in fact, around 20% of the people along their lifetime, they tend to develop this heart failure. And as I said it, it's not just a local phenomenon, but in fact, a global phenomenon as well. So even if we try to think of Western countries, I would say like the US as well, or any of these Western countries, they are not spared. All of them tend to suffer quite a lot. And in fact, what happens is even when we are trying to compare the heart failure, in fact, the mortality can be compared very well even to the cancer. In fact, not just for men, but also for the women as well. And its survival rate, if we are trying to think about the most common cancer, for example, in men is prostate cancer, otherwise the breast cancer in women, it's even worse than that. Isn't it a bit pitiful? So, so what can be happening? So even when we try to think in terms of South Asia as well, especially India, we are aware its prevalent is pretty high. I would say the reported figures are around almost 1%. But I must say, during my practice as well, I have seen, at least in India, the practice, the percentage seems to be prevalence seems to be even much more higher. And when we are thinking of the medicine adherence, because one of the key things is, are they first of all adequately being treated for that or not? Definitely, unfortunately, it seems not so much. Then comes the adherence, which I said it as well. It goes less than half of them. So for example, if we are trying to treat to the patient, we have started a medication. So I would say out of 10, up to less than 25% may be adhering. But yes, adherence may go even up to 50% as well, but it can be pretty low. And what are the reasons for that as well? You will be surprised. I'll share some more insights for that. One of the key things, especially about the South Asian population, especially in India as a whole, is it tends to have one of the highest percentage of young population, in fact. And South Asia is emerging as a diabetic capital of the world, especially when we are going more and more in the south part in Chennai or even in Tamil Nadu states as well. Unfortunately, the incidence rate of diabetes is quite a lot high. And I am aware that currently, in fact, China tends to have a huge, one of the maximum largest population of diabetes, but soon India is going to overtake them as well. Is this something which we all should be proud of? I don't think so. So let's try to summarize in the meantime as well. What about the current treatment and guidelines which is there? For example, whenever we are thinking of heart failure treatment. So the thing is, we have to try to balance what is happening is among the vasoconstrictors, the RAS inhibitors, or whenever we are trying to target the natriuretic peptides as well. So on the basis of that, I think most of the people will agree, even in our audience as well, that especially for there are two types of entities which we all come across for the heart failure. One entity is the one with reduced ejection fraction. The another one is heart failure with preserved ejection fraction. The one for reduced ejection fraction, so the most commonly used drugs are according to the NYHA class, New York Heart Association, of their symptomatic basis. So then we come across that sometimes aldosterone antagonists. Okay, but if someone is really a bit more symptomatic, that is the time when we think of like stopping the ACE or ARBs or okay, and then we can think of start to switch over to the RNE inhibitors. Especially in the last few years, RNE has been becoming a bit more popular as well, and I see a wider audience for that. RNE inhibitors, especially in the West, we call it the single patented molecule is called as Entresto, in fact. Okay, then if the patient is again in the class of like around class 3 to 4, the hydronitrates seem to be having a very interesting way of acting, and they are pretty helpful for such kind of patients as well. And if we tend to see if someone's ejection fraction is less than 35%, but yes, we do expect at least more than 1 year survival rate. And if there's QRS widening as well, that is the time when we think of even the implanting or going for the implantable cardioverter defibrillators, in fact, as well. And as I said it, yes, if the QRS widening is present, left bundle branch blocks are present and all, then we start thinking in terms of the cardiac resynchronization therapy, in fact, okay? And yes, if those patients are very symptomatic and the heart rate is more than 70%, but one thing I wanted to highlight in this, if someone is having an arrhythmia, like an atrial fibrillation, we should try to avoid ivabradine. Otherwise, as I said it, if the patient is heart rate is only high with a heart failure diagnosis, yes, ivabradine definitely is a drug of choice. However, if in spite of trying all these things and the patient is going into the stage of refractory uh, uh, heart failure, that you have tried all these drugs and all, in spite of that, still the uh, patient is really becoming symptomatic, then we have to start thinking of the palliative care. Otherwise, the left ventricular assist device or the transplant or investigational studies as well. I can never forget a, a simple interactive question to the people in my audience. Are you aware in the whole Asia, which center did the first LVAD in whole Asia? I feel proud to say that I was there. In fact, I was working as a resident at Narayana Hridayalaya, Bangalore, at Dr. Devi Shetty's hospital. So it was way back in around 2008, 9 approximately, when the Asia's first LVAD was done. Can you imagine? It was not in Japan, not in Singapore, not anywhere else, or not even Taiwan. which is said to be leader for all those things. But it was in Bangalore. Okay, now coming back to our topic. So heart failure, I must say, I have been passionate about it, especially since my training days as well, like around, as I said it, around 2008, 2009 as well. So we have been getting exposed to it. Dr. Bhagirath was the one who did this, in fact. Anyways, now coming to the, as I said it, one of the earliest medicine, what we always try to use for these heart failure with reduced ejection fraction always is like ACE inhibitors with beta blockers, unless and until there is any contraindication. One of the key things always is up titration of the maximum dosage. So once we start them, it's not like this that we just stop over there. We just keep on building up the dosage as well. And then even still after that, or if the ejection fraction we come across like, okay, it is less than 35%, that is where the MRAs should be added up, okay? And after that, you still have a up titrated. Even after that, if we still come across like, okay, they are still symptomatic, there's still problem is there. And otherwise, yes, if someone is having problems in tolerating the ACE inhibitors or the ARBs, otherwise, yes, one can think of the ARNIs, okay, other than the ACE inhibitors. If there's QRS widening, so what is happening? The ventricular depolarization is getting affected as well. For then, we have to start thinking if the candidate is suitable for the CRT, cardiac resynchronization therapy. And as I said it, of course, if someone's heart rate is more than 70, ivabradine will be a drug of choice. But if sometimes if the heart rhythm, when we have assessed it, and we notice that the patient is in a heart rhythm like atrial fibrillation, that is the time I must say it's a unique entity, digoxin. So recently, I must say this is one of the neglected drugs, I would say, especially in UK practice. I have seen that it is pretty commonly used. And the digoxin, a recent meta-analysis was done as well, in which they saw that atrial fibrillation patients with heart failure, they tend to benefit quite a lot with the digoxin. And of course, if they're still refractory and all, we have to think for the palliative or LVAD therapy. What about Dapagliflozin? I'm sure we all are coming across hearing more and more names like SGLT2 inhibitors, especially like Dapagliflozin. How can it help? So, as I already said it, that this is the SGLT2, the sodium glucose cotransporter 2 inhibitor. So what happens is a lot of times they start to think like, oh, this is an anti-diabetic drug. Okay, it's a really good one, even for the diabetes control as well. Can it be really used, for example, for the treatment of heart failure as well? We are aware, yes, for the diabetics, wonderful drug as well. But what about those patients if someone is having without diabetes? So let me try to share you. So this was a study which was designed, wonderfully designed, I would say. Ours was one of the centers as well. I'm aware, even in UK, a lot of patients were, of course, enrolled globally. Our team had been part of the enrollment for the DAPA-HF studies as well. And I still cannot forget in Netherlands when we had been using Dapagliflozin. So some of the friends and colleagues, they used to advise like, oh, this molecule has been doing so well. And then this is how it led to the interest of the, I would say, the physicians, especially in the Western world, that can this molecule be tried also for the treatment of diabetes? And as you can see, this is how it led to the interest of the development of the DAPA-HF study. It was a worldwide study. In fact, as you can see, most of those patients were pretty symptomatic. Ejection fraction was not so good, and NT-proBNP levels were pretty high as well. And yes, you had to exclude some of the patients with type 1 diabetes. Then comes the EGFR if it is less than 30 ml per minute. So if someone's renal parameters are compromised, and they were followed up on regular intervals. For example, 2 weeks before starting of the study, okay, then 2 weeks after the study, then at 2 months, then at around 4 months, in fact, at regular intervals. And the main thing was, of course, the primary endpoints for this study was cardiovascular death, heart failure hospitalization, and otherwise, if someone needed a urgent study. So as we can already see, it's a global study, literally ranging from the wild, wild west to the wild, wild east as well, from Japan and Asia, Asia Pacific, Latin America, Western Europe, North America, and everywhere, in fact, as well. So when they try to compare the dapagliflozin with the placebo, as we can see, uh, the population matches quite a lot, especially in the inclusion criteria as well. The baseline criteria are pretty much similar, especially ranging from the symptoms, the systolic blood pressure, the renal parameters, or the whether they had the diabetes or not, and what kind of baseline medications which those patients have been taking. As we already summarized earlier, it can range from the ACE inhibitors, beta blockers, the MRAs, even the patients who had been on ICDs or even CRTs as well. So it was a good mix of population who were proposed. And finally, McMurray et al., they published in the Bible of Medicine, which is called as in New England Journal of Medicine. Okay. So what were the primary outcomes of the study? As we can try to see when we try to compare in terms of the cardiovascular death or the heart failure hospitalization, or even the urgent heart failure visit as well, those patients tend to have a significantly lower number. As you can see, this is one of the lowest p-values which we come across, especially in our clinical practice. I would say like 0.00001. Okay, when we try to see. Then similarly, when we try to see, for example, for worsening heart failure event and even cardiovascular death rate as well, then we can, of course, notice that the death rate was significantly lower, and even the worsening of the heart failure the events as well was significantly lower as well. And one of the important things the heart failure patients tend to suffer is the sudden cardiac death. So the sudden cardiac death was, of course, pretty low, especially when we try to keep on looking up at regular time intervals during the follow-up. The things start becoming more and more and more with the passage of time. So that's why it's not always good, just to wait for like few months what had happened. No. What about later on? What about the annual success? What about the effect on the annual mortality? Okay. Then how about the secondary outcomes? So even for the heart failure hospitalization, as I had already said it, when we try to look carefully at with the passage of time, so for example, at the end of 1 year itself, this graph seems to be widening, isn't it? And later on, of course, it tends to widen further when we are trying to look at the biannual rate. Of course, dapagliflozin seems to be having an upper hand for that. And when they try to look, see, heart failure patients are not like this, that once they get hospitalized, they become better and they are done. Unfortunately, no. So what about the repeat hospitalization rates as well? So we can notice that this molecule, the patients who were on this molecule, the repeat heart failure as the heart failure as a etiology to get admitted to the hospital as well was much lesser, in fact, for this. And one of the key things, I must say, like we tend to use a questionnaire, what is called as the Kansas City Cardiomyopathy questionnaire, to see how is the quality of life for such kind of patients. So on that as well, we did notice that it tends to be significantly better for whenever if someone is taking treatment like this. And as I had already said it as well, when we try to look not just, for example, 1 or 2 points, like 3 points, a significant number is called as more than 5 points improvement. So similarly, then we notice that majority of the patients who has been on dapagliflozin, they tend to have a significant improvement. And as I said it, this is what we all are interested. And In fact, not just the quality of life. See, as I said, it is easy to start treatment for any kind of patient. But the most difficult thing is, can we, are we treating them right? That is what is the most important thing. And that is what I think we all should be focused upon as well. So that is the reason. So the quality of life tends to matter quite a lot, especially for such entities of patients. So as we can notice as well, the quality of life improvement was also pretty much significant for these. And as I said, it all-cause death rate was significantly lower as well. In fact, for those kind of patients. So we all are interested, what about the safety parameters? When we try to notice the renal adverse events, or otherwise fracture, or even the hypoglycemic events as well, they are all hypoglycemic events are pretty much comparable. In fact, we are aware its mechanism, as I had said it, the SGLT2 inhibitors, in fact, it tends to affect that. But on an overall basis, adverse events with this were not much, in fact, so which did show that it seems to be pretty safe drug as well. Okay. And one of the other important things, what we all are interested in looking about what about the serious renal adverse events? As we can see, the p-values is also like less than like 0.009. Okay. And even the acute renal injury, because we do come across a lot of those patients tend to have this problem as well. When we try to such patients, then we could notice the p-values was again pretty significant, in fact, for those. So there are some studies which had shown, or some of the publications, they were trying to highlight that UTIs has been having a higher number, especially with this molecule. But as we notice over here, it's not significant at all, even for the genital infections rates as well. And even the major hypoglycemia effects, so it is pretty much comparable to the placebo drugs, which was used even for the study. One of the interesting side effects everyone tries to talk or divert our attention is the phoneus gangrene. So if we can notice it, in fact, interestingly, for the dapagliflozin, it was not at all reported, isn't it? The only patient which was reported by the investigator was the one which in fact, is placebo, not on the dapagliflozin. So whenever you're trying to really have a deeper look inside, you try to do a subgroup analysis as well. So this is a very interesting slide. Why am I saying is, as I said it, this has been a molecule which has been popular for the diabetes initially, okay? So when they try to look even for the non-diabetics, okay, even for the non-diabetics as well, it is a significant improvement in the quality of life. As I said, it is on the parameter of cardiovascular death, the heart failure hospitalization, or even the urgent heart failure visit as well. In fact, even for the renal parameters, as we already said it, whether it is compromised renal function in terms of EGFR, is it less than 60, or even if more than 60 as well, what we notice is that it's a good number and it didn't lead to the worsening. So especially during the heart failure, we do come across a lot of those patients whose renal parameters especially will be worsening, in fact, as well. So that is why, as we can see it over here, the primary outcome, especially by the continuous EGFR, was pretty good with this molecule. And when we try to see how about the acute kidney injury, uh, so for this molecule was around 44%. 44%. So because we are interested, as I said, it is a lot of those heart failure patients, whenever they are receiving their treatment, they tend to have their renal parameters or acute kidney injury development as well with the passage of time. So I will try to summarize that they seem to be really doing good. Okay, it is a pretty well tolerated molecule, and in fact, as I said, it is since it is a once daily dosage. I must say that I have been a big fan of the sacubitril valsartan combination as well. But since after the approval, whenever I've been trying this molecule as well in a lot of my patients, I've been seeing wonderful results with great safety. And as I said, the tolerance rate is pretty good. The even the discontinuation is uh, pretty fine, I would say. And why is that? Because as I said, it's just once daily dosage. So once daily dosage, if I have to, God forbid, like if I have to take any kind of medication, I will always prefer a once daily dosage rather than trying to take something in which someone says to me that I have to take it morning and evening as well. It already tends to make someone more and more sick. In fact, okay. So I am noticing that in the chat, are there any questions? Okay, let me see. Wonderful. I'm going to thank you so much. So I can already come across some questions as well. I'm going to come back to those questions very soon. I'll try to finish these interesting slides, and I will try to answer these questions. So trying to give you a overall summary. So what tends to happen is, as I had already said, being SGLT2 inhibitors, especially what happens is uh, in the tubules of the kidney, we are aware that the glucose tends not to be reabsorbed. So that is why glycosuria will be happening. So glucose will be washed out, in fact, and that is where the volume depletion may also, in fact, happen. And due to the glycosuria, there will be a good amount of weight loss as well, which can be happening, in fact, for this. And that is why we do come across like pretty good amount of weight loss. Then there will be, of course, a preload decrease as well, and which finally leads to, on an overall basis, diuresis is going to happen. In fact, glycosuria or is and all will be happening. So there are a lot of trials as well which has been happening. We are aware that DAPA-HF, yes, we all went through the paradigm heart failure study as well, which is already there for this. And there has been a shift study which did try to include, for example, for the Evidencebased as well. So in that as well, when they try to see, we are aware, Evidencebased, I must say that it's a unique group of drugs. Its mechanism of action is pretty much different. But if still the patient tends to remain in heart failure, but in sinus tachycardia, it's a great molecule. So what happens is, one of the key things which we all should be aware, that the heart, why we try to control the heart rate, why it is important is, the heart failures, the heart's coronaries, they get the blood supply whenever they are in the diastolic phase. Okay, only during the diastolic phase they tend to get those good supplies. So that is why, so diastasis is the phase you try to increase it. So that is why a very high heart rate is not good as well. And that is why not just in any kind of arrhythmias like the atrial fibrillation and all as well, we try to reduce it even in heart failure as well. Otherwise, sorry, otherwise these are the patients who tend to develop uh, complications as well, like tachycardiomyopathy, and they may be able to develop. Okay, so as I, I feel lucky, I mean, to know these people. Deepak Bhatt is an amazing cardiologist from US. Eugene Brownwall, I think everyone will agree as well. So they said it like it's like a momentous victory, because it is really a pillar whenever we are thinking in terms of the treatment for such kind of patients as well. And whenever we are thinking, like later on as well, the guidelines that started coming up like those, the latest ones is 2019 Canadian Cardiovascular Society heart failure guidelines as well. They did include for the dapagliflozins, okay, for the treatment and to bring improvement in the symptoms, but and also the quality of life as well. And as I said, one of the worst things associated with the heart failure patients is about the hospitalization and the cardiovascular mortality. So not just that, in fact, we are aware that, as I said, the biggest confusion tends to happen is, what about those non-diabetic patients? So it is more of a myth that only for diabetic patients we are using this, but it's not at all a problem. Even if the patient is diabetic or non-diabetic, we can use it for both the groups, in fact, and it is irrespective of the diabetic status. In fact, as I already said, it is, and we all are aware that we tend to look forward always to the US FDA, and they also have now approved, in fact, in May 2020, as we can see, that it tends to definitely decrease the cardiovascular death and also the hospitalization. And Foxiga is the commercial name with which it is available globally. Literally, I think world is becoming a small place for all of us, in fact, and even for our patients as well, which tend to move from one part of the other world to the other world as well. And it is available throughout the world as well. And I must say, it is pretty economical as well when we try to compare for the pretty economical in terms of the options which is available, in fact. Okay, so one of the key things, let's not try to forget that that whenever we are trying to treat those heart failure patients, let's try to think that, are we able to give them a better quality of life? Is the therapy is going to give them mortality and morbidity benefits or not? What about, because see, I don't think so anyone would like to get admitted to the hospital in spite of having the problem. So can we really help them or not? And so that is what is one of the key things. And on the basis of that, I would say that let's try to have a more sympathetic approach for our patients and try to give them a better quality of life. And we let's not forget the medicine which we practice is should be based on evidence. Evidence-based medicine is what we practice, not that this person said it like this person said it like this. No. So let's try to base our practice on the data which is available. Let's always try to go through what is happening as well. And as we saw, like DAPA-HF study has been a landmark study with global acceptance, with a global mix of populations as well, and on the parameters and the primary endpoints which we already shared, seems to be very interesting. And I would really suggest that let's not hesitate. And I would say, like, even in my day-to-day clinical practice as well, it has been a pretty interesting mix as well. Let me try to go through some of the questions which we all are coming across, in fact. Thank you so much. Okay, let me try to go through the interesting mix of questions which I can come across. I will try to answer more and more questions, of course. So what happens is, as we already saw the EGFR range, if you want, I can even try to go through the EGFR range, because this is, as I had already said, it's not a bothersome criteria. It's not a bothersome in the sense, like, so for example, the acute kidney injuries has been reported. It does happen, especially whenever we are trying to treat any of the patients, but it's not much. Okay, so I will try to show you those over here as well. So there were those kind of patients as the concerns which is being shared over here, those similar concerns. So as we can see it over here as well. So mean EGFR, even of those patients which was being used for the Dapagliflozin, was around 66. So even for those kind of patients as well, it should not be really a big trouble. And yes, So about the, okay, one question I can see it about the titration. About the titration as well, always start from a lower dosage, okay? And always up titrate, always up titrate. This is for any kind of medication as well, whatever we are trying. This is one of the other things as well, where a lot of our colleagues, uh, we need to, I think, catch up. Catch up means, for example, we once we start those patients, it's not like that our job is done. During the follow-up as well, we should try to see if they are not developing any adverse effects, and if they are not developing any side effects, and if they are still doing good and all, we should up titrate those medications as well. Always start from the lower dosage and keep on up titrating as well, and there's to the highest possible dosage, in fact, as well. About the dosage of MRAs. MRAs as well, as I already showed you in my basic talk in the earlier slides, that if someone's ejection fraction is less than 35%, and if the patient is symptomatic, this is a really good alternative as well, in fact. And if there are no contraindications, it should be added up, okay? Okay, then I can see, okay, wonderful, wonderful. Okay, good, good. Appropriate time, I would say, according to the guidelines, what I could share you in these earlier slides was, so initial things is always what the guidelines say: ACE inhibitors, beta blockers, add them up titrate them. After that, if you do notice QRS widening, or okay, as we can see it over here, or the symptomatic, we can even think of, if the ejection fraction is less than 35%, we can think of ICDs and all. We have already tried, added up the MRAs as well, still not controllable. Then we can think of RMEs. That is otherwise time when you can even think for the Dapagliflozin as well. Okay, so it's a good, I would say, a good experience, and I must say that the data set as well, which has been coming, in fact, for such kind of patients, it's really good, and it is pretty reliable molecule. And the data, as we could see, a lot of times, Asian population, always Asian physicians, they tend to complain like, oh, a lot of patients where this has been tried in the Western subset, not in our, the Asian subset as well. What about because Asians may be having a little bit of different gene pool, in fact. So is it going to really be helpful for such kind of patients as well? So that's where, if we look in the Asia Pacific, it is a good population for which it has been tried. And as I said, it with the usage of telemedicine nowadays in Corona situation, a lot of our patients have become really, really smarter. Okay, they are using those apps. So wherever you are there, our patients are always in touch with us as well, and patients are really becoming smarter. No one wants to compromise anything on anything less. So even for us, as we don't want to compromise on the quality of care which we give to our patients. So why should a patient, compromise on the care which they deserve as well? So that's why they do get in touch with you as well. So what I am trying to show, even in this slide as well, the data set included more than 20 countries. 20 countries, as I said, from the wild, wild west to the land of rising sun, from US to Japan, and it literally covered almost all the continents as well: Western Europe, the South America, Europe, Asia, Pacific region as well, from almost everywhere. So we cannot complain for this, that, oh, there was a subset of patient or subgroup of patients which was not covered, in fact. Are there any further questions?
I think, sir, most of the questions have been covered. I think, sir, one more question is there regarding glycosuria.
Okay, so we are aware. So what happens is, as I try, let me try to show you that slide itself. It's a very beautiful slide. So we should know what is its mechanism of action. So the mechanism of action, what happens is we should be aware that what is the mechanism, in fact, the SGLT2 inhibitors, okay? And that is where we can understand. So as I already said, it is, yes, dapagliflozin does tend to lead to the heavy glycosuria, and sometimes I'm aware like even up to 70 grams per day, okay? Because what is the property of glucose? Glucose, we are aware, it is more of a osmotic diuretic, okay? So on the basis of, because this is the reason which tends to lead to the polyuria in diabetes, in fact, okay? So it can happen, but when it, as I said, it is important thing is, does it really affect? So it's not so bad, but the good part is we are aware that, as I already said, it will tend to lead to the glycosuria, and but it's not on an adverse side, in fact. And even during the DAPA-HF study as well, when they try to look or compare it with the placebo, in fact, as well, there were no such reported significant adverse effect as well with that. So yes, glycosuria will tend to happen, and as I said, it even up to, I'm aware, like up to 70 grams per day, in fact, as well. And it may be sometimes associated with tiredness, but most of the times it is clinically very much manageable, in fact, as well. Okay, and as I already said, it is the name itself, the SGLT2 inhibitors, stand for the sodium glucose co-transporter inhibitor, in fact. And I wish there would be more slides in the nephrons. So if we look over here, how it tends to happen. So it is, yes, it does happen, but it is pretty much in the safe range. And as I said, it even during the clinical study as well, when they try to compare it with the placebo, there was no significant adverse effects associated with this, in fact. Okay. Are there any further questions?
The results of Emperor Reduce trial, which has been recently rolled out in ESC, and where they failed to show the CV and all-cause mortality, but showed reduced hospitalization due to heart failure in HF patients with reduced ejection fraction.
So this is another important things as well. I must say, especially with my little bit of clinical experience, I have been like more than almost 60 publications as well. Even in guidelines, some of my papers are associated, referred to. Okay. So what I would say is, let's try to have a little bit of patience as well. We should always try to have a little bit of open mind. Open mind is uh, in the sense like, yes, there will be some problems whenever a molecule is new, and a lot of things which we keep on coming across as well. With our growing experience, we will be knowing more and more details as well. Even for example, when you said it is okay, uh, that now at least earlier, for example, few years back, if someone would have said it like, oh, dapagliflozin or SGLT2 inhibitors, can they even cause reduce the cardiovascular mortality? Is it possible? Most of the people might have said, oh, no, not at all, not at all. But scientific studies were done for that, focusing on those parameters. And it was seen that, yes, it has been able to take care of those parameters as well. And I'm sure for the mortality and morbidity benefits as well, there are more and more subgroup analysis which is being happening, in fact. And I think it should be pretty positive, and I think the scientific community will be looking forward to more data sharing with some of the leaders from the Bristol Myers Squibb group, or even from the AstraZeneca representatives as well. And let me tell you, try to give you a little bit of insight as well. Even in US, when we try to think in terms of how much is its popularity, it is one of the most popular drugs, not just for diabetes, in fact, even for the heart failure as well, with more than 1 million prescriptions. Because I do visit US as well for my friends and for my training as well. I was there, in fact, as well. So this is what I would say. And I'm pretty positive about its safety profile, and the way in which it is able to affect the quality of life for the patients, in fact. Yeah. Okay. Are there any further questions?
No, sir, there are no further more questions, I think.
Okay, wonderful. So thank you so much,
You
everyone,
have, you
for
have
sharing.
answered all the questions, sir.
It has really been a pleasure to interact with everyone and to be able to learn together about the insights of this wonderful molecule, Foxinga. And it seems to be pretty good. As I said, it try to have a little bit of patience. And as I already said, we practice is what is called as evidence-based medicine. And the evidence seems to be pretty positive so far, especially for this. And we are looking forward to even more data as well. I am aware some more group analysis is being planned for this unique molecule. So maybe if everyone is fine, I would also ask our representative to give some insights, if possible, please.
Sir, first of all, thank you for your nice and beautiful deliberation and presentation. And thank you for taking all the questions. I would like to conclude this meeting and thank you for your valuable time, as well as thank you for all the doctors who have attended. We having 18-19 doctors who have attended this program. So thank you on the behalf of AstraZeneca from all the participants, as well as thank you, sir, for your valuable time and spending with us.
My
Good day,
pleasure.
sir. We would like to conclude the meeting.
My pleasure, indeed. Thank you all.
Thank you, sir. Good night, sir. Good night. And good day to you, sir. There is UK.
Yeah, thank you so much. Bye-bye.
Thank you, sir. Bye.